Yeah, good evening to all the distinguished delegates and our eminent speaker. I, Sanjeev Kaul from Zydus Medica, is honored to welcome all of you to this scientific digital platform called ClearTalk. On behalf of Zydus Life Science, I would like to express my most sincere gratitude to your presence in this scientific webinar. Giving you all a small brief about ClearTalk. ClearTalk is one of initiative of Zydus, which encompasses one of more facets of Unite Against Dyslipidemia. As you know, in India, 1.254 crore population are being uncontrolled with LDL cholesterol, which increases cardiovascular risks. And for that, a recent development in the field of management of dyslipidemia brings you bempedoic acid as an add-on to the choice for LDL cholesterol management. Hence, this session of Clear Talk is focused for one of more development that pharma and medical fraternity are witnessing. That is late-breaking clear outcome trial presented in ACC 2023. So it is basically to upgrade the knowledge of the late-breaking CVOT trial and management of LDL and dyslipidemia. Well, to this program ahead, we have our eminent speaker, that is Dr. Kavita Tyagi, with us. So, just giving brief, she is an eminent cardiologist at Gangaram Hospital. So, she will be taking the session on bempedoic acid through the lenses of clear outcome trial. So, good to see you, ma'am, here. Before we start, we just wanted to update all the participants that if you have any question or query, you can anytime post item to us in a comment section. So now with further ado, I would hand over the session to Dr. Kavita Tyagi. Thank you, ma'am.
Yeah. Thank you so much for inviting me for this session. As you have given actually the very nice introduction of the topic itself. So I'll proceed with welcoming to the Clear Talk. So bempedoic acid through the lenses of clear outcome trials. So the entire story begins with LDL, and we all know that lower is better, and if it is taken for a longer period, it will be better. And there is almost a 23% relative risk reduction when we achieve reduction of LDL to the tune of 1 millimole, that is 38.7 milligram per deciliter. And that keeps on going on as time advances further. Now, we all know these trials, all historical trials, and they have given us significant information, and we are practicing like that on the patients, and our patients are getting benefit by that. So if we see each millimole per ml reduction of LDL gives more CV event reduction according to number of years in trials and comorbid conditions as well. So if we see this by example, the people who are staying in the trial for more than 6 years, they have got 36% relative risk reduction. If we see the risk of non-fatal MI, CSD, death or stroke percentage over 5 years, and if we see this clinical profile, CVD plus diabetes, CVD plus metabolic syndrome plus bad glucose, without, in all the clinical conditions, when LDL is least, so percentage of these non-fatal MI is the least. So it seems to be clearly hand-in-hand relation with the LDL quantity in the body and the risk of cardiovascular disease and CSDs. So management of dyslipidemia is high on priority, and the statins are the first-line therapy, but we have some concerns, obviously. So concern number 1 is, do all statin users achieve LDL goal as per recommendations? Number 2, how to achieve after maximally tolerated dose of statins? So concern 1, do all statin users achieve LDL cholesterol as per guideline recommendation? Now, this is also one very huge confusion in clinical scenario, that other than cardiologists, other fraternities are not actually very clear in stratifying the patients depending on other risk factors other than coronary artery disease. And there it defines the level of LDL patients need to achieve. So I'll start from the extreme risk group, which is again divided into category A and B. So CAD with more than one feature of high risk group. Category B, CAD with more than one feature of very high risk group, or recurrent ACS, that is within 1 year, despite LDL less than 50 milligram per deciliter or polyvascular disease. So this we need to understand that recurrent ACS, that is within 1 year, or more than one feature of high risk group. What is high risk group? Pre-existing ASCVD, diabetes with more than 2 other major ASCVD risk factors, or evidence of target organ damage, or familial homozygous hypercholesterolemia is very high risk condition. What is high risk? More than 3 major ASCVD risk factors, 2 major ASCVD risk factors, with more than 1 moderate risk conventional risk factors, and more than 1 other risk factors. What are more than moderate? More than 2 risk factors, and low risk group with more than 1. Lifetime CVD risk of more than 30%. Low risk is 0 to 1, that is almost nothing major ASCVD risk factors, and lifetime CVD risk of less than 30. So that is how we have to classify our patients, our ACS patients or CAD patients into extreme high risk, very high risk, moderate, and low risk. And that is where comes the catch of keeping your LDL at the desired level. So if we see this revised LDL target population for our country, treatment goals and when therapies to be considered. So in low risk, see, everybody needs to know it, that LDL-C in low risk people also needs to be less than 100. Moderate risk, when it comes to high risk, it becomes 70. When very high risk, it becomes 50. And extreme high risk group, that is recurrent ACS within 1 year, we require to keep our LDL less than 30. And that is where people are not wanting to believe it, that LDL can be kept so low, because once you keep your patient's LDL very low, their family physicians or whatever, they're informed that, oh my God, this much LDL is not good for your health. And that is what we need to understand. So if we see European cardiology 2019 targets, low risk less than 115, moderate less than 100, and very high risk less than 55. According to these guidelines, it is less than 55, but we know our Indian cardiac profile patients, we become cardiac patients at a younger age. Our coronary arteries are complex disease, our mortality is high, our morbidity is high, and we are more prone for these diseases more than these Western population. So this also we need to understand. Based on revised guidelines, how many patients do have controlled LDL? So this is a very, very well discussed Da Vinci study. 18 countries of Europe are involved. Patients number quite high, primary, secondary prevention both. And this is the data analysis. The 27.6% eligible patients are receiving high intensity statin. The 30% patients achieve lipid goals with high intensity statin. So there's a huge gap which is existing between what we want, what we need, and what we are doing and what we are getting. 37.5% eligible patients are receiving high intensity statin, and 22% achieve lipid goal with high intensity statin. So even if you tend to give high intensity, then also we are far from our goal of achieving the desired status. Concern 2, how to achieve LDL-C targets after maximum tolerated dose of statin. So now what is to be done? Because so far we have been experiencing giving high dose statins. Now what to do next? So now fortunately we have many combinations with us if we analyze them. So check baseline LDL and then classify patients like this: familial hypercholesterolemia, complete statin intolerance, and ASCVD. So with high intensity statin, 50% reduction. If you add ezetimibe, 65%, bempedoic acid 65 to 70, and if you use combination of bempedoic with ezetimibe, then 75%, and if you add PCSK inhibitor, then 85%. So it means you require to add medications to your intensity statins for achieving the goal of LDL. In familial hypercholesterolemia, also, if you combine high intensity statin, bempedoic acid, and PCSK inhibitor, you can achieve it up to the tune of 85%. So it is not something which is undoable. It is something which looks to be very much doable, but only thing you have to add on medications. And for the complete statin tolerant patients also, so fortunately we have now these combinations like bempedoic acid, ezetimibe, and we can add on the PCSK9 inhibitor if not controlled by these two. High intensity statin, has low adherence, which leads to high MACE events. This is an established fact now. So 23,000 patients post-ACS who were prescribed high-intensity statin after index event. 66.4% of all patients presenting with ACS did not take high intensity after discharge. More than 50% of patients had drug interruption and off therapy within the first month after the index event. Non-adherence to high intensity had a strong association with high mortality to the tune of 16%. So coming to the molecule of today's talk, that is bempedoic acid, which is ATP citrate lyase inhibitor. It is a first in class LDL lowering drug. So I think by now, all of us, we have known this drug, we have understood this drug, and all of us, we have used this drug, quite user-friendly, doesn't seem to have much problems with the patients. But when to use and why to use, that indication should be clear in our mind. So reduce uncontrolled LDL with maximum tolerated statin dose, mixed dyslipidemia, familial hypercholesterolemia, or high risk. Statin intolerance or whom statin is contraindicated. 180 milligram orally with or without food. Now, if you see this confidence nationally and internationally, you see various CVOT trials. Now, coming to this, how does it work? So we all know it is ACS, ACL enzyme inhibitor, and it is not activated in skeletal muscle as this inhibitor is not expressed in muscles. Now, when we are giving bempedoic acid to our patients, so certain pharmacodynamic or pharmacokinetic things we need to know. Its half-life is 21 hours. 70% of it eliminates through kidney, 5% through feces, and less than 2% unchanged through kidney. So in renal impairment, it is not a matter of concern. Hepatic impairment, no dose adjustment required. So clearly, it is not a concern image. In patients where you need to monitor, all patients keep on assessing serum uric acid. So obviously prior history of gout. In people more than 60% years of age, 60 years of age, taking steroids or fluoroquinolones with renal failure and a history of tendon rupture, warn patient of potential for tendon rupture and advise patients for rest at first sign of tendinitis or tendon rupture. So tendon rupture, people more than 60 years, having some doubt on that, plus uric acid. So all things related to your uric acid, your muscles, your tendons, and your gout. So that way you can remember it. In people whom you need to discontinue, obviously, pregnancy, breastfeeding, we don't have enough evidences. And taking simvastatin more than 20 or pravastatin more than 40, avoid concomitant use with bempedoic acid, consider lowering dose or switching statin. Discontinue if tendon ruptures, consider if joint pain, swelling, joint pain, inflammation, etc. So these are the few things which are, I think, not very difficult to remember, to memorize, or to keep in mind while using this trial. So let us talk about this trial, late-breaking clinical trial in ACC 2023. So statin intolerant patients, screening, 4-week running period, treatment with single blind placebo. Then these are the visits, study completion, 1620 primary, 4 component, MACE at least 620, 3 components MACE. So primary endpoint, effect of bempedoic acid versus placebo on 4 component MACE. CV death, non-fatal MI, non-fatal stroke or coronary revascularization. Minimum of 1620 primary 4 component events, treatment for at least 2 years. Median follow-up of 40 months. So statin intolerance, bempedoic acid, CV outcomes, not assessed. Statin intolerance in 15% treated patients prevents patients from achieving LDL cholesterol. Bempedoic acid approved for lowering LDL-C. So this was the reason why we had this trial with us. Primary endpoint, 4 component MACE, non-fatal MI, stroke, revascularization, death. Hierarchical testing of key secondary endpoints, sequential testing, And this is the clear outcome demographic data. These are the clear outcomes. Primary result, relative risk reduction of 4-point MACE 13%, 3-point MACE 15%, fatal or non-fatal MI 23%, coronary vascularization 90%. Effect of trial regimes on severe events. Among statin tolerant patients, treatment with bempedoic acid was associated with a lower risk of, so 3 component as we have seen, 13, 15%, 23%, and 19%. So clear outcome, not only reduced LDL 21.7%, but it achieved 22.2% reduction in HSCRP also. Safety, if we see the safety, serious adverse events 25.2% in comparison to placebo, which was almost same. Discontinuation in 10%, myalgia 5.6, discontinuation due to myalgia 1.8, but almost same as placebo. So if you see the safety profile, it doesn't seem to be really bothering them. So it becomes the first ACL inhibitor and first oral non-statin to demonstrate statistically significant reduction of MACE4 events in patients with or who are at high risk of CVD with documented statin intolerance and elevated LDL-C. So to conclude, it is an effective alternative for statin intolerant patients, clear outcome. So now we are not scared of prescribing it all alone when patient is not tolerating statins. That is what the story is about. So it is well tolerated in mixed population of primary, secondary prevention patients, unable or unwilling to take statins. LDL-C and HSCRP reduction. It lowered LDL-C by 21.7% and HSCRP by 22.2%. A small increase in incidence of gout polythiasis. Primary and secondary endpoints. The primary endpoint, 4-component MACE was reduced 13%, 3 was 15%, MI 23%, and coronary vascularization by 19%. So it is an effective approach to reduce major cardiovascular events in statin tolerant patients. Thank you so much.
So, ma'am, thanks a lot for this discussion. So I have few questions that has been raised by few of the doctors, delegates who have attended this. So with your permission, can I ask, because I have already received few questions.
Yeah. So we can go ahead because one patient is waiting.
Yeah. So I will 2-3 questions I can, because I have received 7 to 8 questions, but at least 2-3 questions I want from your side. So one question is, as per revised ESC 2019 guidelines, many patients have uncontrolled LDL cholesterol, but they don't have any complications. So should I increase the dose of statin or to add bempedoic acid or azithromycin?
Yeah, so again, that will depend on in which category your patient is falling. Okay. So we have to classify our patients into high risk, A or B, extreme high risk, moderate high risk, low high risk. So that as a clinician we should do, and depending on that, where in which category our patient is fitting in, should add statin. Not tolerating or if not controlled, then we should add azithromycin, and now we have bempedoic acid. And if not by control by that also, then we have PCSK9 inhibitor. So we should go like that.
Okay, ma'am. Another question, just 2 questions, ma'am, with your permission only. So I have many patients with type 2 diabetics and hypertension. So what LDL target should I keep for these patients?
So less than 70. Anytime less than 70. Yes.
So is it appropriate to keep LDL below 40 milligram per deciliter as per
guidelines? That's a very common confusion actually. And
okay.
Appropriate to keep your LDL below 30 also, and it is said that when we were born, we were having our LDL to the tune of 20 or 30. So that is okay for us. We were born with that much LDL.
So, ma'am, can it lead to the neurological complications?
That neurologist thinks, but we have not found so far.
Okay.
Yeah. Okay, so I'll conclude when patient is waiting. Actually, some emergency is there.
Thank you, thank you. Thanks a lot, ma'am. So
Okay.
I think next time we should get more time because n number of questions are lying with me from the delegates.
Okay.
Yeah, yeah. Thanks a lot, ma'am. This type of
Okay.
activity will be
Okay.
continuing from Zydus end.